Hello, welcome to POC Nurse. My name is Gozi, and in this video, we're going to talk about ventilation and perfusion for the pulmonary part of the Ccrn review. So, in ventilation, there's movement of air from the atmosphere into the lungs, and this air is distributed in the lungs to maintain appropriate concentrations of oxygen and carbon dioxide in the alveoli. So, for inspiration to happen, which is breathing in, inhalation, movement of atmospheric air into the lungs, the brain has to send a message down to the diaphragm. The diaphragm and the external intercostal muscles contract, the size of the chest increases, and air rushes into the lungs because there's decreased pressure in the lungs. The pressure in the lungs is lower than the pressure in the atmosphere, and we know when you have a pressure gradient, things will go from the place of higher pressure to the place of lower pressure. So because the pressure in the lungs is lower than the pressure in the atmosphere, air will rush from the atmosphere and into the lungs. So that's how inhalation occurs. Exhaling is a more passive process. The muscles of inspiration, the diaphragm, and the external intercostal muscles relax. The pressure in the chest increases, and the air rushes out of the chest back into the atmosphere. So, ventilation has two parts to it, inhaling and exhaling. Now, two things control ventilation: the brainstem, and we also have peripheral control of ventilation. So for central control of ventilation, which is when the brain controls ventilation, that's primary control. It's regulated by the blood pH. So the brain will keep track of the blood's pH. When there's a decrease in pH, when there's acidosis, ventilation is stimulated. There's increase in the rate or depth or both of breathing. On the other hand, when we talk about peripheral control, there are sensors in the aortic arch that monitor the partial pressure of oxygen in the blood. Now, this is secondary control of ventilation. So, when there's a decrease in the partial pressure of oxygen, ventilation is also stimulated. In this case, we have hypoxemia, there's low oxygen in the blood. Now, there will be also an increase in rate and depth of breathing, or either or, to compensate for this low oxygen in the blood. Now, for people with like COPD, that retain carbon dioxide, so their partial pressure of CO2, that's their PaCO2, will be high. They just need only mild hypoxemia for their ventilatory drive. If their PO2, that's their partial pressure of oxygen, is corrected to normal, their drive to breathe may be reduced. So, one way to know that your patient is ventilating adequately is to check the partial pressure of carbon dioxide. That's their PaCO2, not their O2 sat, not the end tidal CO2, but their partial pressure of CO2. So that means you do an ABG and then you check the PaCO2 on the AB should be on the ABG. It should be between 35 and 45. And so if a patient is ventilating well, we'll have a normal PaCO2. If the patient is moving enough air in and out of the lungs, the PaCO2 will be within normal values. Now, moving air into and out of the lungs has something to do with minute ventilation. Minute ventilation is the volume of air that a person moves in and out of their lungs per minute. So the normal minute ventilation is 4 liters per minute. Now, if there's an increase in minute ventilation, meaning one of those values has increased, maybe respiratory rate is increasing, maybe the patient is struggling to pull in more volume, that means their work of breathing has increased. What is work of breathing? Work of breathing is the amount of force or the amount of force required for a patient to breathe, amount of pressure required for a patient to breathe. Also, volume is also a factor in the work of breathing. So, work of breathing is a product of kind of pressure and volume. So, if you see a patient and they are working hard, meaning they're using all of their muscles to breathe, they have increased work of breathing. If you see a patient and they're tachypnic, they're breathing fast, it means they have increased work of breathing. And if their work of breathing is increased for a while, they might get fatigued, they might not be able to breathe as well anymore. And when the patient doesn't breathe well, they get hypoxic, their mental status changes, so it decreases. They get confused, they don't follow commands anymore. And then at that point they get intubated, right? So it's important to assess the patient's work of breathing. So the main muscles that a person breathes with is the diaphragm. There are other accessory muscles connected with breathing, the muscles of the neck, the muscles of the chest, and the muscles of the abdomen. So for a patient to breathe normally in a healthy fashion, the diaphragm needs to be uncompromised. The diaphragm needs to be healthy. So if in any condition, let's say the diaphragm is weak, it's going to affect ventilation. If the diaphragm is, I had a patient that went to surgery, and it looks like the surgeon had thought that they nicked the patient's diaphragm. Now, the patient didn't need to come to ICU, but they brought him to the ICU because they wanted us to monitor his work of breathing, make sure he was breathing okay. They wanted to make sure that, hopefully they didn't do anything to his diaphragm. Well, the patient was okay, but it just goes to show you how important the diaphragm is to ventilation, such that if there's any mechanical trauma to it, like during surgery, or if he has any weakness to it, like in neurological diseases, ventilation will be affected. But that's not the only thing that affects ventilation. Compliance also affects ventilation. Resistance also affects ventilation. Surface tension also affects ventilation. Now, what do I mean when I say compliance? Compliance is how elastic are the lungs, right? So if a patient takes in a deep breath and the lungs are nice and compliant, they're elastic, the breath will go in nice and easy, the lungs will expand, the lungs will contract to get the air out. Now, if the lungs are not compliant, there will be restriction in the amount of air that can get into the lungs. It will be like a restrictive lung disease. So if the patient has something like fibrotic lungs, maybe they worked in a place with asbestos and they've been breathing in asbestos. They work in a place with coal and they've been breathing in coal dust. It goes in and settles on the lungs and makes the lungs stiff. It's going to be difficult for that patient to ventilate himself or herself because the lungs are not so compliant. So there will be resistance. There will be getting air into the lungs will be difficult. Now, when you talk about, so that was compliance of the lungs. When you talk about resistance, you're talking about how big are the airways. Remember, air goes through the nasal passages, it goes through the trachea, it goes through the bronchi, it goes in through the bronchioles. So if anything decreases the diameter of the airways, let's say patient has asthma, patient has cystic fibrosis. In asthma, there's constriction of the airways. In cystic fibrosis, there's mucus lining the airways, decreasing the diameter of the airways. Right? It's going to be difficult for that patient to ventilate because there's resistance in the airways. The airways are smaller, so it's harder for the air to pass through. So in that kind of patient, like in the asthmatic patient, when they're having an attack, if you've seen an asthmatic patient having an attack, it is so difficult for them to ventilate, to get the air in and get the air out. So those are two things that could affect ventilation: compliance of the lungs and resistance to airflow. Another thing is surface tension, and this has to do with the alveoli, because in the alveoli, the walls of the alveoli have a layer of water in it, and this permits the fusion of gases between the alveolar membrane and the blood flowing past the alveoli. Now, this water has surface tension on it naturally, and that surface tension tends to pull the alveoli in towards itself to make it smaller. So, what the body does to combat this is to produce surfactant. So, surfactant kind of breaks up that surface tension so that the alveoli is more compliant, so that air can go in nice and easy. It'll expand and contract easily. Now, if that surface tension is left as it is, it'll pull in the alveoli and sort of collapse it so that it is less compliant and it's tougher to get air into it. So these three things also affect ventilation, that is compliance of the lungs, resistance in the lungs, and surface tension in the alveoli. You know, the alveoli is where gas exchange actually takes place. So it's really important that the alveoli is compliant and able to expand and contract so that air can get into it in the first place for gas exchange to occur. Earlier, we spoke about pressure in the chest and pressure in the atmosphere. We said that there's a decrease in the pressure in the lungs so that air can move from the atmosphere into the lungs. There's decrease in the pressure in the lungs that's lower than atmospheric pressure, and this allows it creates a pressure gradient so that air can go from the place of higher pressure to the place of lower pressure. We just spoke about surface tension, and it's the same principle. When there's increased surface tension, it pulls in the alveoli, it increases pressure in the alveoli, and it's difficult for air to go from a place of lower pressure to a place of higher pressure. So you can't get air into the alveoli that has increased pressure, and that's where you get atelectasis. That's why the surfactant is very important for keeping the alveoli open and ventilated. Let's move on. So I think in another video I spoke about an asthmatic patient that I had. The patient came in sitting in the tripod position. She couldn't lay back, nothing. She had to sit up and forward to breathe. So when we talk about what's the best position for breathing, it's the patient sitting up. That's the best position for a patient to breathe and ventilate well. Not laying down in a supine position, but sitting up. So even though ventilation is a process of moving air into and out of the lungs, not all the air that's passing through the lungs participate in gas exchange, depending on where the air is. So we have dead space in the airways, and dead spaces are those places within the airways where gas exchanges does not happen. So this is normal. So there is no gas exchange from the nasal passages, no gas exchange in the trachea and the bronchi and the bronchioles down to the alveoli. This is normal, and it's called anatomic dead space. Now, gas exchange normally would happen in the alveoli, but there are conditions that could occur and prevent gas exchange from occurring in the alveoli, such as a pulmonary embolism. So there will be no gas exchange if blood does not flow by an alveoli. So if there's any alveoli that's not been that doesn't have gas exchange occurring at its site, that alveoli also has dead space in it. So it's called alveoli dead space. And of course, it's pathologic. It's a disease state because gas exchange should be occurring between the alveoli and the blood flowing by. So when we add the alveoli dead space plus the anatomic dead space, we have physiologic dead space. So that's it for ventilation, the movement of air into and out of the lungs, the things that affect it, and we talked about dead space in ventilation. Now we're going to talk about perfusion. Perfusion is the movement of blood through the pulmonary vessels, through the pulmonary capillaries. That is, those capillaries that surround the alveoli. If there is blood flowing through these pulmonary capillaries and there is air in the alveoli, then gas exchange will happen. So for perfusion to occur, there needs to be ventilation, movement of air from the atmosphere all the way down to the alveoli. I think I said for perfusion to occur, there needs to be movement of air. No, for gas exchange to occur, there needs to be air in the alveoli and blood flowing through the pulmonary capillaries. So for air to be in the alveoli, we need normal ventilation, movement of air from the atmosphere through the nasal passages all the way down to the alveoli. That's correct. So essentially, for gas exchange to occur, there needs to be ventilation and there needs to be perfusion. Now, anything that affects blood flow past the alveoli, anything that decreases perfusion of blood through the pulmonary capillaries will affect ventilation and perfusion. And this would affect the ventilation perfusion ratio and gas exchange as well. Now, the ventilation perfusion ratio is is shown as a fraction, if you want to call it that, where it is 4 liters of that's minute ventilation, which is 4 liters per minute over perfusion. So the ventilation perfusion ratio is represented by the VQ ratio, where V represents ventilation, the volume of air moving through the airways, and Q represents perfusion, the amount of blood moving through the pulmonary capillaries. Now, the normal value is 0.8, 4 liters over 5 liters, 0.8. In this case, anything that affects ventilation, maybe reduces ventilation, or anything that affects perfusion, maybe a blood clot in the pulmonary capillaries, can cause abnormal gas exchange if the body cannot compensate successfully. Right, so in a situation where a patient is hypotensive, there will be reduced blood flow to the heart. If there's reduced blood flow to the heart, there's reduced blood flow to the lungs, and this can cause poor gas exchange because there's not enough blood moving past the alveoli in the pulmonary capillaries. So perfusion is affected by gravity. So different areas of the lungs get perfused differently depending on the patient's position. So if a patient is standing up, there will be more perfusion at the bottom of the lungs because that area is more gravity dependent. In this case, there will be less perfusion at the top, at the apices of the lungs. In the same vein, if the patient is laying down on their back, there will be more perfusion towards the back of the lungs, that is on the side of the lungs that is down, than at the top of the lungs. So this is why we get the good lung down intervention. So if a patient's left lung, if there's consolidation in there, maybe a lot of mucus, and gas exchange is not happening over there, You don't want to lay the patient on that side. You want to lay the patient on the good side, so the good lung down. In this case, the perfusion will occur mostly in that lung. That lung is healthy, and because of gravity, the blood flow will pull there and flow by there, and gas exchange will occur more there. If you put the patient on the bad lung, if you put the bad lung down, there won't be adequate gas exchange. And if you look on the monitor, the patient will probably have a low O2 sat. So this is how the good lung down helps the patient. When the patient has a normal ventilation perfusion ratio, that's a normal VQ ratio, gas exchange will occur fine. Patient's O2 sat will be normal. There will be no hypoxia issues. Now, if there's a mismatch in the ventilation perfusion ratio, there will be hypoxia to certain degrees. Now, usually, you can give oxygen to correct this hypoxia in certain situations. So let's say your patient is on room air, they're satting fine, they are okay. Suddenly you notice, patient's still on room air, but patient's getting hypoxic. We usually, well, let me give patient some oxygen. Give the patient oxygen, and the hypoxia is corrected for the time being until, the reason for the hypoxia is found out. Maybe a chest x-ray is done, maybe you listen to the lungs and there's obstruction, maybe the patient's wheezing, maybe the patient has asthma or something. So in this case, you give some oxygen and O2 sat is fine. Maybe patient gets some bronchodilators to correct the constriction in the airways, and the patient is fine. On the other hand, you might notice, the patient is on room air, the patient is desatting, and you give oxygen, but, hypoxia is not getting corrected. So there's a ventilation perfusion mismatch here. There was a ventilation perfusion mismatch in the first example because there was constriction in the airway. So even though perfusion was occurring, blood was moving past the alveoli, there wasn't enough air going into the alveoli. So we increased the concentration of the oxygen going into the alveoli and corrected the hypoxia. In this case, where we're giving oxygen to correct this VQ mismatch, ventilation perfusion mismatch, there is no positive response, meaning that the patient's hypoxia isn't getting corrected. There is likely an extreme ventilation perfusion mismatch. Here we might have a situation where blood is flowing by the alveoli, but that blood is not getting oxygenated. There's no gas exchange occurring, probably because there is a problem with the alveoli. So in this case, a shunt is created where blood is going from the right side of the lungs to the left side of the lungs without being oxygenated. The patient's going to be hypoxic. Even if you give oxygen, it's not going to do anything. Patient is going to remain hypoxic because there is no oxygenation occurring, even though, let's say in this case, the blood is flowing by. Let's say there's a problem with the alveoli. Let's say the alveoli is filled with pus, it's filled with fluid, so air cannot get into it. Therefore, there is no gas exchange occurring. So there's an extreme VQ mismatch in this case. So let's say perfusion is occurring, no ventilation occurring. Extreme VQ mismatch, and we have a shunt, a pathologic shunt. For the Ccrn, we're going to talk about two types of shunts: anatomic shunts and pathologic shunts. So in the anatomic shunts, it's an issue with a person's anatomy. So because of the anatomy, blood is moving from the right side of the lungs to the left side of the lung without being oxygenated. Two examples are a ventricular septal defect, where there is a hole between the right and left ventricle, and also an atrial septal defect, where there is a hole between the left and right atria. A pathologic shunt is in a condition where we have ARDS, acute respiratory distress syndrome, ARDS. In ARDS, which I feel like that's always comes up on the Ccrn, in ARDS, there is blood flow through the lungs, but no gas exchange is occurring. So the blood goes through the lungs, however, it doesn't get oxygenated, and it flows from the right side of the lung, not oxygenated, to the left side of the lungs. So this patient is going to be in big hypoxia. They're going to be very hypoxic. No matter how much oxygen you give them, there's going to be no oxygenation because for some reason, the alveoli just isn't probably holding any air for gas exchange to occur. So big deal on the CCRN exam. I remember I got questions on ARDS. I don't remember correctly, but I know I got the ABGs on there. Treatment for a shunt that's causing refractory hypoxemia, meaning you're giving oxygen, but it is not treating the hypoxia. The patient is still hypoxic, is to give oxygen. Not only oxygen, you have to increase PEEP, positive and expiratory pressure. So most likely this patient will be intubated because they're in severe distress. Oxygen by non-rebreather is not working, face mask is not working, nasal cannula is not working. So this patient will most likely get intubated. And when the patient is intubated, then you can manipulate the PEEP. Now, PEEP, positive and expiratory pressure, it essentially keeps the alveoli open, and you can increase it as needed. So when you increase it, there's increased surface area for gas exchange to happen. So we're talking about treatment of a pathologic shunt where there's refractory hypoxemia. We said we're going to give oxygen. We're going to give the patient PEEP. We're going to reduce surface tension of the alveoli to prevent the alveoli from collapsing. We're also, so now these are the advantages of PEEP. These are the advantages of PEEP. So decreasing surface tension of the alveoli to prevent atelectasis, which is collapse of the alveoli. We're going to recruit more of the alveoli to increase the chances of gas exchange and oxygenation. Adding the PEEP will also increase the time for gas exchange to occur. So when PEEP is added to, in addition to giving oxygen, there could be a possibility that you could reduce the amount of oxygen that the patient is getting if the hypoxia is starting to get addressed. So initially, when you intubate a patient, you give 100% FiO2 um, of oxygen, and maybe with the increase in PEEP, you could reduce the FiO2 the patient is getting, so from 100% down to a lower number. So we're going to stop here talking about ventilation and perfusion. We talked about, the process of ventilation. It's controlled by the brain. It also has peripheral control. It's a process of moving air into and out of the lungs. We talked about the things that affect it: compliance and resistance, compliance of the chest wall, compliance of the lungs itself, resistance in the airways. We talked about perfusion. We talked about the ventilation perfusion ratio and the importance and significance of that. We also talked about the significance of gravity regarding perfusion and how places in the lungs that are gravity dependent get perfused better. Hence the good lung down nursing intervention to help a patient oxygenate better. I hope you found this video helpful for your as you prepare for your Ccrn exam, and I will see you in the next video. Bye bye now.